ICOR comes upward and backward, the knee gets stable as much as possible. Next slide. This is my new design model. This is not the perfect joint which I want to make. This is a model of my joint. Next slide. This is the fabrication process of my model. Next slide. So here the advantages of my new design. It is lightweight, it is simple, and it can be flexed up to 135 degree, and as it allows flexion during walking in swing phase, so it consumes less energy than the other knee joint available, and the fabrication process of this knee joint is very easy. Next slide. So here is the case study I have made in a patient of genu decurvatum with the available single axis drop lock knee joint with my 4-bar link polycentric knee joint. Next. Next slide. So here is the experiment process. The patient works with my knee joint and the patient's condition without the orthosis. Next slide. So here is the result of temporospatial parameters, which shows the stride length, step length increases in 4-bar orthotic knee joint with the 4-bar orthotic knee joint, and the stride time, step time decreases, as which all shows that the energy consumption and gait pattern will be better in 4-bar orthotic knee joint. Next slide. This is the kinetic and kinematic variables. So I have made this joint in our institute. So here is some availability of some advanced experiment products. So it is limited, but I have done through some. Next slide. So here is the discussion and conclusion. So after discussion, we can conclude that the 4-bar orthotic knee joint is can be more studied and researched to produce its manufacture in industry, and it can help patient in walking faster and more naturally. Next slide. As all design has some limitation, so here are some limitation which it has in the study. There is a small number of subjects I have experiment with, and the 3D motion analysis and force plate was unavailable, so the study was limited in this manner. So next slide. Thank you. If you have any question, you can ask. Thank you.
Thank you so much for sharing your research and insights with us. I now invite the next presenter to the stage, Mr. Bilal Hussain Malik. I welcome you.
This is working. Scroll করতে হবে, উপরে নামিয়েছি। Very good afternoon to respective all. I am going to present my paper, which is entitled as Comparative Efficacy of Radial Shockwave Therapy and Myofascial Trigger Point Release on Pain and Function in Upper Trapezius Trigger Point. Author 1 Bilal Hussain Malik, MPT second year, NLD, and author 2 Sri Vibhuti Sarkar, MPT in Orthopedics, IC lecturer, PT NLD. Next. Myofascial trigger point pain syndrome is a condition of wide group of muscle characterized by taut bands and trigger points known as hypersensitive points in more muscles. It's defined as a hypersensitive spot in a taut band of skeletal muscle. It is painful on compression and stretch. It can give rise to typical referred pain pattern. Myofascial pain syndrome is thought to be the prime cause of neck pain nowadays. Myofascial pain syndrome is classified as acute or chronic on the basis of temporal and trigger point. It's also can be classified as active or latent on the basis of clinical presentation. And the pathology behind this is the most accepted as energy crisis hypothesis, where it is said that there is increased demand of nutrients and ATP, but there is decreased supply due to the continuous contracted state of the muscles, and there is also increased effect of acetylcholine. Next. The purpose of the studies, there is no studies available which compare the efficacy of myofascial trigger point release and shockwave radial shockwave therapy on pain and function of upper trapezius trigger point. So the purpose of this study was to compare the effects of radial shockwave therapy and myofascial trigger point release on pain and function in upper trapezius trigger points. Next. Methodology. In this study, 47 subjects are included in two groups. In group A, there was 23 subjects with the mean age of 28.13 years, and in group B, there was 24 subjects with the mean age of 28.88 years. Next. Inclusion criteria were subjects male and female willing to participate with the age of between 18 to 45 years and at least having one active trigger point release, and the symptoms should be presented for at least 3 weeks. And exclusion criteria were musculoskeletal conditions like history of cervical or shoulder trauma, neurological conditions like cervical disc hernia and other systemic conditions like RA, AS, coagulation disorders, subjects with cardiac pacemaker, any local skin disorders such as like eczema over the shoulder region, any red flag sign or positive results in cervical compression and Sparling test, and subjects with neck pain or upper trapezius trigger points were approached with the study proposal, and the number was 100, and subjects not fulfilling the inclusion and exclusion criteria were excluded, and the number was 53, and subjects willing to participate were evaluated and written informed consent were taken and was randomized into two groups, and the number was 47. And then demographic data and baseline data were collected. Pain intensity was measured by visual analog scale, pressure pain threshold was measured by algometer, and functional status of the neck was measured by neck disability index, and they were in group B 23 subjects and in group A 23 subjects, and in group B 24 subjects were treated, and data collection was performed at the end of the 10th session, and then data analysis was done. Next. In the group A, the intervention was radial shockwave therapy, and in group B, myofascial trigger point release was performed in the form of deep transverse friction massage. Both were performed in prone lying position, and in both the group there was a standardized exercise program which consists of muscle energy technique of the upper trapezius trigger point and chin tucking exercise, and there was also home exercise protocol which consists of isometric of neck muscles and self-stretching of upper trapezius, and there was ergonomic care. In statistical analysis, we use SPSS 25 version, and descriptive statistics was used to summarize the subject's demographic detail, and chi-square test was used to check the homogeneity of male-female ratio. Then paired sample t-test was used to analyze within group comparison and for the outcome measures, and independent sample t-test was used to analyze between group comparisons for the outcome measures. The p-value was considered to be significant at a value of less than equals to 0.05. The demographic characteristics shows that the values were homogeneous, where the p-value is more than 0.05 in both the group. Next. In within group comparison, we can see there is a statistically significant difference, whereas the p-value in both the group and all the parameters are 0.00, and P-value in between group comparison, we can see there is no statistical significant difference where the P-value in all outcomes are more than 0.05. These are the graph. Next. In discussion, in this study found that there is highly significant statistical improvement within both the groups whereas there is no statistical difference between group. That indicates that both the intervention is equally effective in treating the particular condition. The improvement in group A might be because of the introduction of fresh microtrauma to the taut band. Those tissues are in energy crisis state by the violent impact of shock waves that results in new angiogenesis and consecutive healing. There is analgesia, increased blood nutrients flow to the myofascial trigger points, selective destruction of unmyelinated nerve fibers, reduced substance P and increased nitric oxide release. Another possible mechanism is hyperstimulation, indicating that a shock wave triggers the release of endorphins and other analgesic molecules by activating the descending inhibitory system. The mechanism behind the improvement in group B might be breaking of molecular adhesions between the muscular microfibers by deep transfer friction massage and consecutive increased fluid and circulation in the energy crisis state tissue. Moreover, prolonged deep friction massage of localized area may give rise to lasting peripheral disturbance of nerve tissue with local anesthetic effect. There is an increase in the time of excitation contraction coupling from muscle itself, and it leads to an influence on changing the neuromotor driving mechanism by afferent pathways and therefore decreasing the active muscle stiffness. Muscle energy technique helps to elongate the muscle fibers and to re-establish the length tension relationship. There is also improvements in the muscle strength, leads to improvement in pain and function. In conclusion, we can say that in treating myofascial trigger points of upper trapezius muscle, treatment protocol of both the group is equally effective in terms of pain, pressure tolerance and neck function, and no one is superior over the other. Limitations are, it's a single blinded, single centered study. There was no control group in this study and no long-term follow-up has been taken. Clinical implications in treating myofascial trigger points of upper trapezius muscles, both of the treatment protocol can be applied clinically. Thank you.
Thank you so much. If there are any questions from the audience, please don't hold back. We encourage you to ask questions. Thank you. Next on our list is the presentation by Mr. Atul Botra. I welcome you. I request you to please maintain the timing.
Hello. A very warm good morning to all the jury members and all the A very warm good morning to the jury members and everyone present over here. I am Atul Bodra, MPT second year. Want to present my paper. Next. The title is Radial Shockwave Therapy for Improves Pain and Pressure Pain Threshold in Piriformis Syndrome, a randomized control trial. Author is Atul Bodra and Saurav Saha. Next. Introduction. Piriformis syndrome is a peripheral neuritis of the sciatic nerve caused by an abnormal condition of the piriformis. It commonly goes unrecognized or misdiagnosed in the clinical settings. Basically, there are two types of piriformis syndrome. Primary one is for the anatomical cause, and the secondary is the precipitating cause like microtrauma, macrotrauma, etc. Recently, shockwave therapy has been found that it is effective in treating the low back patients because it applied on the lesions and revascularization and stimulate or reactivate the process of connective tissue and bone healing, thereby relieving pain and improving the functions. Next. Aim of the study is to find out the efficacy of radial shockwave therapy on pain and pressure pain threshold in the subjects with piriformis syndrome. Purpose of the study, piriformis syndrome is one of the main cause of the buttock and sciatic pain, leading low back pain and leg pain. Radial shockwave therapy has shown been effective on the results of pain and pressure pain threshold. So the best of all, there are very few shreds of evidence available in the effects of radial shockwave therapy for the treatment of low back pain, specifically on the piriformis syndrome. So the purpose of the study is to find out the efficacy of radial shockwave therapy on pain and pressure pain threshold in the subjects with piriformis syndrome. Materials and methods, it was a randomized controlled trial. Study area was NILD, Kolkata, India. Sample size was 161. Source of sample was assessment killing of the NILD. Study duration was December 22 to November 23. Next. Study design, it was single blinded randomized controlled trial, was approved by the Institute Ethical Committee NILD and was prospectively registered under the registration number that is given. Next. Inclusion criteria, age between 30 to 60 years, both male and female. Subjects having low back pain and or buttock pain, leg pain and paresthesia, positive tenderness of the piriformis muscle, positive flexion, FAIR test, positive piriformis restive test, and NPR scoring between 3 to 7. Exclusion criteria, having any recent surgery or fracture, deformities, having disc prolapse, any history of the pathological condition, malignancy, etc., any neurological condition, any intra-articular or epidural injections, any red flags, or non-cooperative and psychologically unstable subjects. Sample size was 35, out of that control group was 17 and experimental was 16. Randomization was done using the simple randomization using cherry picking method, and randomization was performed by first author. This is the flow chart. So total 161 subjects were approached for the study. Out of them 126 were excluded due to lumbar radiculopathy, negative FAIR test, declined to participate in hip pathology. Then after that, written informed consent was taken from the 35 subjects and randomization was also done for the 35 subjects. Demographic data and pre-intervention data were collected, that was the NPRS, and PPT was done measured by the algometer. Group A was N number was 16 and the group B was N number was 19. Group A shockwave therapy along with the standardized exercise and the home exercise program, and in group B a standardized exercise program and the home exercise program, and both were given for the 6 sessions, 3 sessions per week for 2 weeks. There were 2 dropouts from the group B. So the data analysis lastly were done in the N group was in the group A was 16 and the group B was 70, so no intention to treat was taken. Intervention in group A, shockwave therapy was given 2000 shocks for 7 times per second with an impulse of 5 Hz, and it was delivered from the 15 mm of head. And then standardized exercise program containing stretching of the piriformis muscles, then straight leg rising, spinal extension exercise, and ergonomic cares. Outcome measures were NPRS and PPT, that was measured by using the algometer, and 3 consecutive measurements were taken and the best were taken for analysis. Statistical analysis, SPSS 25 version was taken, and non-parametric data using the chi-square test, parametric data using the independent sample t-test. For within the group analysis was done by the pair sample t-test, and between the group was done with the independent sample t-test, and p-value was set as less than or equal to 0.05. This is the demographic details of the baseline, and it was homogeneous. Next. This is the graph. Next. This is the baseline outcome data for the group A and B, and it was also homogeneous. Next. This is the graph. This is the intra-group comparison of the NPRS, and both group A and group pre-intervention and post-intervention gave a significant difference, and also the PPT pre and post with significant differences. This is the graph. This is the intra-group comparison. So in group A, the mean difference was 2.31 with a standard deviation of 0.79 for the NPRS, and in group B there was 1.94 plus minus 0.82, and difference of mean differences was 0.37 plus minus 0.28 with a t-value of minus 1.31, and it was a non-significant. For the PPT it was minus 2.94 plus minus 1.81 in the group A, and group B it was minus 1.50 plus minus 0.69 with a intra-group comparison 1.32 plus minus 0.47 with a t-value of 2.79, and p-value was 0.009, and it was a significant. So only in the PPT it was a significant difference between the group. This is the graph. Next. Further discussion, piriformis syndrome is a neuromuscular condition that occurs due to any pathology or anatomical cause.